One of the things is, peds emergency medicine is so fulfilling and meaningful, and we have some incredible highs and some incredible lows, all within a span of 8 to 12 hours. And I don't think you can match that in any specialty. And somehow the lows stick with you as Velcro. The highs kind of you think about them and then they disappear. And I'm sure you have too. And we've had a lot of lows in our careers, and to pick one is always difficult. Doesn't mean that that's the worst or that's the most challenging one, but maybe for a conversation, I can start with one, and then we can see where it goes.
Hey everyone, welcome to HUMED. Everyone in healthcare has a story that they never forget. Some are beautiful, some are difficult, and most are never told. This is the space and place where folks in healthcare talk about the moments that change them. Welcome to HUMED, where we talk about the emotional, moral, and human realities of medicine. I'm Dr. David Spiro. Thanks for being here. I'm incredibly honored and delighted to have Dr. Jay Pershad with us today. He's a professor of emergency medicine and pediatrics at George Washington School of Medicine and Health Sciences. He's a PEM faculty at Children's National in DC. He's a self-described PGY31. We're pretty close there, Jay. We may be about the same age, and a passionate clinical educator and advocate for high-value care. He's previously served as editor for 6 years of AAP's flagship educational product, Prep Med, and is a teaching faculty at AAP's PEM Landscape course, and recently joined their planning committee. He enjoys working with learners of all levels and is currently a practice of medicine course faculty and coach for 2 cohorts for medical students at the GW School of Medicine. He recently served as clinical chief at Children's National ED, and in prior roles, he was the director of outreach education, medical director of transport, and served as the program director of the PEM Fellowship at Le Bonheur Hospital in Memphis. Caring for families at the bedside and the challenge of undifferentiated presentations to the emergency department gives him great joy, drives him to be a lifelong learner and strive for excellence in human experience. He didn't include this in the bio, but active member of our PEM listserv. I really enjoy listening to Jay's comments and is a great contributor and has been a leader, frankly, in the national at the national stage of the work we do, pediatric emergency medicine. Jay, it's incredibly awesome that you decided to join us today, and I'm incredibly honored to have you on the show.
My pleasure, David. We have a common. We go back. UAB is where we go back. I still remember. I think we were both alums for our fellowship there. So
yeah, so that we had joint training there. So I may be a PGY31 too. So it seems like yesterday when we were residents, and now I turn to my left and I turn to my right when I'm working a shift, and I realize I'm the old dude in the room.
That's right. That's right.
So I would love for you to tell a story and get into what you wanted to share. I know that you had done some prep and thought into what you wanted to share on the show. So I'll turn it over to you.
Sure. I think, one of the things is, peds emergency medicine is so fulfilling and meaningful, and we have some incredible highs and some incredible lows, all within a span of 8 to 12 hours. And I don't think you can match that in any specialty. And somehow the lows stick with you as Velcro. The highs kind of you think about them and then they disappear. And I'm sure you have too. And we've had a lot of lows in our careers. And to pick one is always difficult. Doesn't mean that that's the worst or that's the most challenging one. But maybe for a conversation, I can start with one, and then we can see where it goes. If you want to discuss the highs, the lows, whatever.
It's
But
always good to discuss both, right? Because what I've learned actually in my role as a leader that maybe 20, 30 years ago, especially around quality things, we tend to focus on what what did not go well. But I've been consciously working over the last few years to focus my team on when things go well, to talk about that as well, because I think there are great opportunities to learn. But sure, we could start off with the low and maybe we can end with the high.
Okay. Well, I think the low is really it maybe happened in the last few years. I was working at our community site and it was 6:30 in the morning and the EMS brought in a teenager in cardiac arrest. And this was a short transport time. And the only story we got, no name, nothing, is she's otherwise well from what they know. And she was found at a friend's house. And fast forward, there were no parents there, and we went through the full resuscitation, and this came in asystolic, but we went through the full 20, 30 minutes and looking at all reversible causes and all of that. And then finally pronounced her. And then the parents came, and these were Latinx parents who spoke Spanish only,
And when you say pronounced her, you mean that you declared death.
declared death, right?
Mm-hmm.
And then 10, 15 minutes later, I think the family came, and it was obviously an incredibly difficult moment to start explaining to them. I don't speak Spanish, so I had to use a video interpreter. We don't have in-person interpreters at this site. And took him to the bedside, and then we started having a conversation and trying to connect with them compassionately and at a time of incredible grief for them and their worst moments in their lives was it started well, but then the Wi-Fi kept disconnecting. Wi-Fi kept disconnecting. And each time you log in, you have a new interpreter coming on. And and I think that whole, without sort of belaboring it, but not able to make that human connection with this family. And the stark disparity at main campus, because we see a lot of Latinx patients, I think we could get an in-person interpreter. It's a completely different, but just reminded, it still gnaws at me that I wasn't able to tell them things that, try to tell them, but each time you're going through an interlocutor. And so I think those, their faces, the face of the teenager, they stick with you forever. But this would be maybe one of the lows I would say sticks with me quite a bit. Mm.
What is different for you when a teenager comes in, or is it different when a teenager comes in versus an infant? We see, at least in my experience, the vast majority of children that have a cardiac arrest in the field that are non-traumatic are often SIDS babies or children in the first few months of life. And is there something different about a teenager that passes away unexpectedly versus an infant? Or what is your experience with that?
Yeah. No, funny that you ask, because the why is what gnaws at all of us. And it wasn't evident initially, but what we gathered from the medical examiner report that this ended up being an opiate overdose. She had gone out with some friends in the night, and the last time they had seen her, the parents, was the night before. And I guess we don't know the circumstances, but the cause of death was narcotic overdose. And really, uh, the reason it hits you harder is obviously here you have someone in the prime of their life, who've had, um, and their family is just devastated by this incredible loss of a child like that. But I think it also, in many ways, I think the emergency department, we're sort of a microcosm. We are the humanity in the front lines. We're the microcosm of what's happening in society, and some of the earliest indicators, whether it's opiate overdose, mental health crisis, um, the poisonings that happen and toddlers die from a variety of ingestions. I think things start with us in the emergency department, we're sort of the canary in the coal mine, and and this, by the time this happened, obviously the opiate crisis was well known to everyone, but it hits you harder, definitely, because you're always questioning yourself. Could I have done anything differently? Could I have done anything differently? Because the patient got excellent care in the field by the pre-hospital team, and then we sort of continued here. But uh, and I think when you sit back and reflect and debrief with the team, um, ultimately the things that help you get over it is when the team says, I think Jay, you did everything you could. I think we all did everything we could, and repeatedly during the resuscitation. And it's always been my practice to say, am I missing anything? Am I missing anything?
And when you,
the
yeah,
answer.
just for the audience,
Mm,
when you say that, just to give context to it, what you're referring to is you're actively resuscitating a child, and you're thinking in your mind as the team leader that at this point it's futile to continue, but you share that comment, and I've actually, maybe it's because we went to UAB and someone taught us there, but it's my practice as well to do the same thing. I look around the room because, and I'm curious about your rationale, but for me, I want to make sure that everyone in the room, all the medical personnel in the room, feels like we've done everything that we can, and everyone has an opportunity to speak up. Is that fair to say? Is that the reason why you make that comment?
yes, yes, absolutely. And also to recognize that, there's a vulnerability piece that sometimes in the heat of the moment when you're there are opportunities where you may miss things, and every person on the team is valuable and their input's valuable. And I think that uh and that is also because trying to declare death is one of the hardest things we do, and you want to be sure that you've not left any stone unturned. And I think if there's anyone in the room can provide some input in that area, I think is, and like you said, to make them also feel comfortable that despite the best we do, we don't control outcomes. And so I think
You
those
know,
are, mm, mm,
what I was going to say is that I think that one of the reasons why I started this podcast is to unveil the work that we do, and your resume, your background is so incredibly impressive, and the work you've done both on a national level and a local level. But you ended your bio with something that's very important, is that you still love to take care of children at the bedside. And the other thing that we do when we're at the bedside is we're simultaneously taking care of patients and also teaching. There's this thing that's happening, both are happening at the same time, which to me is the magic that keeps me excited about coming in to work. When you have a situation where you have to give family bad news and you have a learner with you,
mm,
you may have a resident who's a pediatrics resident or an emergency medicine resident. You may have a fellow who's studying to become what we do in pediatric emergency medicine. You may have a medical student with you in the room and as part of the resuscitation. But you're the most experienced person in that room at this point in our careers. And so, what do you do now when you are working with learners, and you're at DC Children, so I assume you're working with learners almost all the time,
yeah.
and you have to give bad news? How do you approach that? Usually there's a few minutes between the time there's the resuscitation and then walking to a quiet area, private place where you're giving bad news. How do you approach working with learners in that art of giving bad news, which is not a frequent, it's an infrequent enough event that you don't get to practice it over and over and over again during your training, maybe over your career. So how do you approach teaching that?
Yeah, no, I think that's a great question. I make it a point. Number one is I never ever I wouldn't say never ever, unless it's like a third year PEM fellow. It's part of the humanity piece of emergency medicine is you have to pivot very quickly from that incredible low to maybe taking care of a 18-month-old uh, with a radial head dislocation or something. But I think the point is that I do make it a point to take them with me, at least give them the opportunity. Look, I'm going to be talking to this family, and if they're in the room, which is what we're all about, family presence during resuscitation, I think it's they can see what's happening, and then we can talk to them at the bedside. Um, but that private moment, I always take a learner with me because I think they need to hear that conversation. And like you said, it's an infrequent event, and just also acknowledging the death with silence. I think a lot of people do that, and I have made it my practice. You learn over the years that, I think acknowledging them. And um, one of the other things I've done is if the family is in the room, and this is something I've started doing, and another one of those lows that I was referring to is uh, the family was, the parents were at the bedside. We declared that they saw the resuscitation. We had a moment of silence, and then I don't know what got into me. I just said this with this family. I said, "What is it that you want us to remember about Johnny?" And I didn't think they would answer in that moment when they're seeing this. Some families can react differently but I felt like this family was calm enough, at least externally, to and when they spilled out what they liked about Johnny. He was fun loving, he was kind, he loved airplanes, and this was a traumatic death. And I think it even now, I think you sort of get emotional about listening to the story. But it was funny afterwards. But back to your original question, I think it's always important to take the trainees with you. But before I go, I always tell the trainees it's an opportunity for me also to think about what I'm going to say, right? I think, and we all sort of have a style to it, and we sort of develop it over the years. But it's like, in the moment, it's like, obviously you're empathetically announcing what happened and not being wishy-washy about it. So they need to hear the team members and the learners need to hear that you're not wishy-washy, that this patient has died. That has to go through, and then take it from there. Each family is going to react differently, but letting them know that everything was done. If there's the SIDS babies that you talked about, I think there's often an element of guilt, but I'm very, very deliberate about saying did nothing wrong. You did nothing wrong. And I think I want them to hear that, because sometimes they don't hear the science, the mechanics of what happened. I think um, I want the learners to hear that as well, because that's not the moment. That's the moment where you want to take the load off the family's mind and focus on what has just happened. And so I think those are some of the strategies. I don't know if that answers your question, but taking the learners with you is important because each one is different. There's no cookie cutter sort of approach, and I'm sure you'll agree with that as well. And mm, I think
So,
with family
so
presence, you have the support of maybe a chaplain or a social worker with you, and so sometimes that helps.
yeah, I usually do have. Actually, I learned this during fellowship that it's really important to have other people in the room. One, because of safety reasons, because sometimes folks have different reactions with extreme grief. So I usually have a social worker, maybe a chaplain in the room. Usually, someone is around to be there to offer support and stay with the family if I have to leave after discussing bad news. I wanted to talk to you about a concept that didn't exist I believe, when we started training in fellowship, but has evolved over time, which is you had mentioned families being in the room of during a resuscitation. 50 years ago, 60 years ago, when emergency departments started to become a thing and our specialty began, families were not in the room during resuscitations. Families were usually just told to wait in some other room, and the doctor will come and give them updates. And there has been a change over the last few decades where now it seems like there is a better response with the families in the room during the resuscitation. And I'm wondering if you could speak to that. And because there's a part of it that almost feels not intuitive, that a family is watching a team compress the chest, breathe for a child, do these things, some of which could be considered invasive or are invasive, and they're watching the team work on trying to save a life. What is that has happened over the course of the last few decades? And I'm assuming at DC Children's that's your practice now.
Yes, yes, certainly. If the opportunity is there for the parents to be um, at the bedside, that happens. Sometimes it's not feasible. They're not immediately available because the child is brought in extremis. But yeah, I think it's that compassion and humanity side. And I think there's enough data now um, in the literature saying that the grieving process, I think, is better if they see what happened. And despite feelings to the contrary, that because we as clinicians, as practitioners, we often worry, what if I say something in the room, or if they see something that's not gone very well, that they may react negatively. But sometimes that's not been borne out. I think in my mind, as long as you can, as a team leader and as a resuscitator, you focus in the moment, that's sort of um, that's your zone that you're operating in, and you forget that you have parents in the room until the time comes. But in the back of your mind, there is, if the resuscitation is not going well, to maybe at least prime them for it. That's an opportunity, I think, for us to. Uh, but I think it's that compassion, the humanity piece, the more data saying that the aftermath of the death for the family, that loss, I think is a lot easier for. I wouldn't say easier ever, but losing a child is never easy. But I think they can. There's not this mystery surrounding what happened, at least in the last few hours or minutes of the child's life. So I think some of it is the change in our practice, and with shows like Pitt now, I think which I have not watched a show, but I've read all the commentary around it because I just can't get myself to watch something I do every day. I just can't. But when I hear the stories, to hear because my kids always tell me this is what happened, this is what happened. And it's like I think you can tell it's bringing emergency medicine home to families who are listeners currently to your podcast, and I think um, and. With that caveat, I will also say that there are some families who won't react well, right? If they're completely distraught and are likely to interrupt the flow of the medical resuscitation or the traumatic resuscitation of trauma, then I think if you don't have someone by their side constantly, then I would not, I wouldn't automatically say it because people can react differently. But having someone, and when you work at a big children's hospital or even work at a community site, we usually have someone who can be at the parent's bedside. And if they're starting to lose it, then maybe have them step away, but tell them, look, you can come back, whenever you're a little bit in a better frame here to come back. But if they're, you know what I'm talking about. But I think,
But there's a difference, and you had mentioned this was a short transport time, and you've worked in, well, we both did fellowship in Birmingham, but you really spent most of your career at Le Bonheur, which is a very large children's facility in Memphis, Tennessee. And uh, and I'm in Arkansas, where you worked at Lebanon, and I'm assuming very similar to Arkansas Children's, where it's a rural state, and sometimes transport times are extensive. And there's a slight difference. All of these are, it's not cookie cutter and it's different, but there is a dichotomy between families sitting and watching a resuscitation. So the families arrive at the time or shortly after the child arrives and we're resuscitating a child. And then there are times when the family arrives after death is pronounced. So we can't keep resuscitating a child for
Mm.
45 minutes or an hour when it's futile. And when you say those words, does anyone have anything else they would like to offer or do? That's very close to the end of the resuscitation. And then the family's not there. And then they arrive. And I assume you've been in the situation where you not only have to give bad news, but you're also um, giving new news that's bad news to the family. Have you been in those situations? And is it is
Yes,
it is
yes.
it very different?
No, I think you're right. I think the transport times are being rural versus urban, I think is completely is a different animal. But the there are pressures, and I think you may be driving at that in the room to say, look, the family is on their way, the father is on the way, the mother is on their way. Can we continue the resuscitation so they have an opportunity to see this? And that becomes sometimes a tense situation. And then I've been in that situation too, where the outcome is sort of grim to begin with, it internally, but and you're having to make that decision, and it becomes a compromise. I think sometimes if you're towards the end and the family is going to be, 5 minutes away, maybe you can wait. But if it's going to be 30 minutes, 40 minutes, I think you just have to, as a team leader, I think make that decision, and but then after that, when they do arrive, I think do everything we can to support them. I think so. I think maybe that's what you're asking, and the other different pieces in the rural air parts, in not just rural, but the South, the spiritual piece of it is up in the forefront, and I think even praying at the child's bedside who has died, I think is with the help of a chaplain, or is something that is I, I used to see a lot more than I see here, I think.
Do you ever bring your own spiritual beliefs into the forum when you're discussing these things, or do you stay neutral around that?
I stay very neutral around that because I just don't know, because we're such a multicultural environment here, a lot more than in Tennessee is. It's difficult to know what people's values and cultures are, and I don't pretend to. So, but we offer them, certainly, and then would be, certainly offering, but maybe pray in a neutral way, just say God as opposed to specific cultural beliefs.
Yeah, I was actually in a resuscitation within the last few months, and I had a family in the quiet room. One of the family members was in a ministry and invited me to pray with them at
Wow.
the end. And I had never been asked that. And
Mm.
I grew up Jewish, and I'm not from the South. And religion is a Christianity is a very large part of the culture in the South, if I may say that.
Yep.
And I'm sure you experienced that at Lebanon or in Memphis. And I was initially internally taken aback because it was an uncomfortable moment for me um, to be asked, because I didn't know if I didn't know what to expect. It was uncharted territory for me. And actually, it was one of the most beautiful experiences I've had. because what I realized in the moment is that the family was deeply turning towards their spirituality to help support them through a tremendous period of grief for them. And and I was able to take part of it while staying neutral and not having
Mm.
to share my own beliefs or practices. And and I was honored to be a part of it. I think that we talked about this show lifting the veil of what we do, and I sometimes uh, feel like uh, there's a sense of privilege, there's a sense of there's duty, there's all sorts of things you can say, but it is it is an incredibly privileged and honored place to be, to show up to a room wherever you are, room 34, room 10, whatever the room number is. And you walk into a room and a family's going to tell you some things that they would never tell anyone else. And they become immediately vulnerable and open and honest. And to me, that's one of the things that also continues to drive me to wake up. Yes, I just attended a great research conference called the Southern Society for Pediatric Research, and our fellows were presenting, and I was so proud of them. And I got in late Saturday night, and I had a Sunday morning shift, and I was not looking forward to it. It starts at 6 in the morning, and I was up at 4:30 making coffee and getting ready for my early morning shift because it's what we do, and trudged into the hospital. And this was yesterday morning, and I had one of the best shifts of the year, on for multiple reasons, because of the learners and the different cast of characters that was in the emergency department. And I got to have some real beautiful time with families. And I'm curious, just turning this conversation a little bit to our age. I just turned 60. I assume you're close to my age-ish. Um, what drives you to continue to show up? Because I get a sense from your energy that you still love doing what you do. And so what is driving Jay Pershad to continue to show up at 6 in the morning and
Yeah.
see patients?
No, I think you're right. I think you hit the nail. I think as I still enjoy that opportunity to, like you said, it's a blessing to be able to talk to a family at likely their worst moment. No one wants to be in the emergency department. They have visions of perceptions of real badness happening to their child, but also they're trusting you with their most precious family member, right? So that I never forget that privilege. But more importantly, I think I've become a student of the human experience, the patient experience piece, and the connections that you can make with the family, even if it's small talk, but to allay their concerns. And I always tell the learners, I said, don't tell me the chief complaint, tell me the chief concern. Because sometimes the two are different. And I tell them, don't look at the triage. The triage note is a starting point, but it doesn't tell you the whole story. And sometimes our learners are fixated on that. And but no, you're absolutely right. I think that's the joy of the bedside interaction that I still cherish. And every day, I remember when my children were younger, they would say, "Tell me a good story, Dad. Tell me a good story." And and even now, they were, "Hey, did you see anything interesting?" And they're adults now, but uh, and you can always look back. However, how difficult or challenging the 8-12 hours have been, I think just like you said, I think we need to focus on this is what went well. And usually the parts that go well is the interactions with the family that you have. And if they leave the family, they're discharged, admitted, whatever, addressing all their concerns, I think it's a that piece is joyful. I think the technical aspects over the years have become less important to me. Obviously, I love being at work. The physical exhaustion of a very late evening shift, or, I don't work nights anymore, but the physical exhaustion I can't deny. That's age related, but the actual piece of working, I mean, I just love it. I just love it. I don't think I would give it up for anything. As long as I'm living, I tell my wife, I said, I don't have any significant hobbies, but not in a bad way. I mean, um, I'd love to continue to be able to contribute, either help a learner or help a family or help them connect. And one of the things that I've started doing a lot is I take the medical students, they'll present to you or the residents. With the fellows, it's difficult because they're functioning like junior attendings. But I say, hey, let's go in with like, come in with me. Or I might go in and say, hey, can I watch you when you're interacting with the family? And that gives me, it's two ways. I said, would I have done anything differently? I mean, I ask a medical student because they're totally green and they're coming at it from a different angle. But likewise, also, I might give them some tips. Hey, I think you were too technical in your conversation with this family. I don't think they fully understood the labs that you were trying to explain to them. Or might be helpful if you just sit down, because that's a sign of respect. You're lowering the barriers. Standing up in front of a patient who's in bed with their parents or whatever is, and maybe doing that. And I started practicing this a lot more, is the desire to interrupt. Anytime it wells up in your head, you kind of bring it down and say, let me listen, let me finish, let me let them finish, because that's again a sign of respect. Because ultimately, what are people looking for? Some courtesy, respect, people listening to their concerns. And a lot of times in emergency medicine, you can't solve the diagnosis. You can't always come to a diagnosis, but you can't always get that aha of a reduction of a nursemaid's elbow, or you do a great sedation and it goes well and the child wakes up and says, I can't remember anything of what you did. Those moments are not all the time, but or a diagnostic uncertainty. I think that still gives me a thrill. I think, hey, let's pull the ultrasound machine out, and you see a little, uh, the squeeze is diminished, and this is not septic shock. This looks like myocarditis. Or I think that thrill is there where you can make that diagnosis at the bedside. And so I think it's a combination of both. The undifferentiated patient, the diagnostic challenges. And then the other thing I think that's kept me very nourished is I always follow up with patients that are puzzlers. I still have a
Mm.
list of puzzlers that I have. There are almost like 100 of them right now. But I go back, and because those become teaching cases if something turns out different. And so at our case conferences, there are opportunities to teach. I don't know if that answers your question, but those are some of the ways I keep myself engaged. But the human interaction piece is what really is critical, because you can always do better as a physician. You can always do better. What else could I have done better? Um, Sometimes we're too focused on surveys, but I did not take surveys personally. I mean, I think if you get a negative comment, I mean, that's an opportunity to, hey, what exactly went wrong? I thought it went well, but they didn't.
Uh,
So there must be something there.
so um, I've been thinking a lot. Yeah, it was funny. I was with a learner the other day, resident, and the resident said, "Well, when I'm in my 50s, I certainly won't be doing this." And they were in their 30s or late 20s, and now I'm 60, and um, I had some visions of potentially retiring around this age, maybe, or doing something different. But I have found myself um, thinking about the next 5 or 10 years, and I don't know if I want to do anything different other than continue to practice as long as I can. Um, I'm curious what's in store for you over the next 5 to 10 years, because, like you, I have some hobbies. I do some things. I stay fit. I play pickleball occasionally, and love to go hiking with my wife and various things. But I think about the personality of us that went into emergency medicine. We like to stay busy. We like to stay engaged, and there's also some recent evidence in the longevity world that people who are connected to community and feel like they have a purpose well after what we would consider retirement age tend to have a higher quality and maybe even a higher quantity of life because they are using their mind, they're staying engaged, and they still feel like they're doing something meaningful. And we're fortunate to be living in 2026 and not 1826, where we have medications like statins and other things that can keep us alive and improve the quality and quantity of our life. Um, Whereas in 1826, the mean age of death for men was probably in the 40s or 50s, and now we're in the mid to high 70s for men and early 80s for women. So I'm just curious, what are you thinking about? What's happening with Jay Pershad, and what's your 5 and 10 year plan uh, sitting where you are today?
Yeah. Eh, Certainly, I think, um, we all give some thought to it, and maybe two or three, 65 was when I was thinking of really, when I first, every time I think about it, 65 is when, and I'm 61. So it's kind of when I really want to be the master of my time. I wouldn't say retire completely, but be the master of my time. But the more I think about it, I think as much as the career has been such a big part of my life, I don't think at this point the medicine doesn't define me personally. I mean, I've been a loyal husband for 31 years and father to two adult daughters who are hardworking, kind people, and I think I've been fortunate that they've been relatively healthy, and I think at this point, if they need me earlier, I mean, I might. If at some point they tell me, Dad, you're not there anymore for us, and that sort of thing is, because I spent the early parts regretting sometimes that I wasn't there for them. And, but that's part of our life as physicians. I think, you may miss some weekend events, you may miss some family events and things like that. But right now, I think if I can continue to be available to them and uh, yeah, I think I don't know if that answers your question a little bit, but it's a combination. I think family first, and then I think I still want to be able to be engaged in some fashion and with medicine. I don't know in what fashion, but hopefully I can contribute. And I told my division chief the other day in our annual reviews, I said, if you ever feel that that I'm not at my A game during a resuscitation or something, please let me know because then sometimes I may not have the insight, or I'm so physically fatigued that I'm not there for the learners or not there for the nurses or not there for the team. And let me know. I think um, and I think she was smiling, but I think I will every year I'm going to ask her that. Every year I'm going to ask her that because I think you need to get some feedback as well.
That's sage advice. I've been thinking
And
about that as well. And actually, two of my colleagues here at Arkansas Children's recently retired, and they asked that same question: Am I still relevant? Am I practicing at the level I should be practicing at? And it's very sage advice for those of us that are getting older in years. I'm curious. Do you work 8 or 12 hour shifts in your current
right.
facility?
So we work, it's actually nine. It's eight plus maybe 1 hour for overlap kind of things. So,
And so I've noticed recently that I tended, when I was earlier in my career, to enjoy the evenings. Sometimes I even enjoyed the overnight shifts. And then the overnights became painful. And after the age of 50 or 55, I stopped working overnights. And then um, I don't know what your experience is around day and evening shifts, but I tend to find that the morning shifts uh, I tend to do better. I'm more alert. I'm engaged. And then sometimes we work 8-hour shifts. So we have a 2 p.m. to 10 p.m. shift and a 3 p.m. to 11 p.m. shift, which is the latest I usually work till 11. And I find that sometime around 9 or 10 o'clock, I start to feel tired. And I'm
Mm.
curious, uh, at this point in your career, do you, is it similar for you, or when do
Very,
you
very,
find yourself fatigued?
yeah, very, very similar, very similar. And I think, um, it, I don't know. I think as I've aged, my sleep has not been as restful as it used to be, and but I tell myself, look, some nights are going to be great rest, some nights are not going to be rest. So, but once you get to work, I think you get energized. I always say, good resuscitation is better than 10 cups of coffee, or a happy interaction with the family can certainly rejuvenate you. And I think,
Or a
uh,
difficult interaction?
or a difficult interaction, or a procedure that goes well, I think can suddenly you forget it, and then before you know it, it's 11 o'clock has come around or midnight's come around, and then you're starting to wind down, and so yeah, no, I think physical exhaustion, like I was telling you earlier, I think is, and the different ways of each one of us handles it differently, but that is real, I think. And yeah, I stopped working, I think, after 50, 51. The occasional, it's the recovery that's harder. I think, it takes 3, 4 days to recover and get back into after a deep night. So that's the difficult part. It's not the medicine piece of it.
I appreciate that. Well, listen, I want to thank you for sharing your story today. I know that giving bad news is difficult, and bringing that story to our audience is an opportunity for them to learn. And I certainly learned from some of the things that you shared today. And it's been a great conversation. When you were at Le Bonheur, they were incredibly fortunate to have you, and DC Children's is incredibly fortunate to have you as a mentor and a teacher, and probably above all else, a master clinician at this point. And we're lucky in the pediatric EM community for you to be sharing your wisdom and knowledge with us. And thank you for being on the show.
Oh, you're very kind, David. I think I will reciprocate everything you said about you as well. And I think you're also a tremendous leader, and what you're doing here, I think, is so important. I think our audience needs to hear this side of the story, and I think like you said, this is totally unprepared. There was nothing we had prepared for. You just said present a story, and we'll go from there. And I'm amazed. I didn't think I would be able to converse with you for almost an hour. Well, so hopefully the audience will find it interesting.
I think they will. The
Okay.
one last thing I'll share with you before we end, and you said something I want to repeat to the audience before we go, because this show is HUMED, human medicine. And you said something that is maybe the most sage thing that you said, which is you said family first. And you're going to retire at some point. I am going to retire at some point. And what's happening at GW, what's happening at Arkansas Children's, it will continue to happen. Medicine will still be practiced. It will be turned over uh, to a different team of folks that will continue to grow and learn without Jay and without David. But for us, what remains is our family, our children, our spouses, our family members, our friends that we're really close to. And medicine can take a toll on our families at times, because this field that we're in, I missed events. I've missed Christmases, Hanukkahs, New Year's, Thanksgivings, because I was in the emergency department, because we operate in a 24/7, 365 environment. And um, I just want to honor what you said. And you had said earlier before we went live that you're in DC because your daughter's at GW, and I think that's beautiful. I think it's wonderful that you have such a beautiful family, and you're close with your children, and married for all these years, and just want to honor that, because I think it's important to remember that our family I always say that the most important thing in life is love, and giving and receiving love. Everything else is very, very, very secondary. So
Oh,
thank you for
thank you.
being on the show.
Oh, my pleasure. My
Okay,
pleasure, David. Okay.
bye.
Thanks.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.